One of the interesting questions is the possibility to combine target therapy with immunotherapy in patients with BRAF-mutated. The KEYNOTE-022 was a trial with a part 1 and part 3, so from the phase 1 to the phase 3, which compared the triplet with the Dabrafenib, Trametinib, Pembrolizumab with the Dabrafenib, Trametinib plus placebo. The KEYNOTE-022 part 3 was a randomized phase 2 study, and the main endpoint was the progression-free survival. The statistical design was very ambitious because looking to the study design and the PFS power, it was the concept was to find at least an hazard ratio of 0.62 or less in order to get the significance. Looking to the data, 60 patients per hour were enrolled in this trial. And looking to the baseline characteristic in the triplet arm, Pembro, Dabra, Trame, we got more patients with M1C, 83% versus 62% in the Dabrafenib group, and also considered both arms, patients with elevated LDH were higher considered and compared to all the other clinical trials. The percentage was 43-45%, in general is 34-36%. But looking to the progression-free survival data, the progression-free survival data looks very interesting because the hazard ratio was 0.66 with a median of PFS more than 16 months for the triplet versus 10 months. It's interesting, but hazard ratio of 0.66 should be considered negative because the study design was ambitious with a design for an hazard ratio of equal or less than 0.62. But still, these data are interesting. The response rate were similar, and looking to the PFS curves, it's interesting to see that the first 6 months are similar, then the curve separate. This probably is the impact of Pembrolizumab. Overall survival, looking to the curves, is pretty similar, but there are two interesting comments to do. The first is that hazard ratio was 0.76, not significant, but looking to the 1 year overall survival was 79% in the triplet arm, while 73 in Dabrafenib plus placebo. That is consistent with all the other data with Dabrafenib, but 79 is the highest 1 year overall survival reached in a clinical trial. Of course, we cannot compare the different, but it's a data. And also, probably most important, that overall survival are affected by post-progression treatment. In the control arm, more patients were treated with post-progression immunotherapy, so maybe that this is a sort of comparison between the combination with the sequence. So we'll see in the future, but the data are interesting with also the ongoing clinical trial. Last point, the safety. The safety profile was consistent with the data from phase 1. Almost 70% of any grade in the triplet combination about the adverse event, and also grade 3 and 4, the grade 3 and 4 adverse event, and 40% of patients discontinued the treatment. So the toxicity is, of course, an issue. And probably looking to the data, looking also to the fact that the patients who get more benefit from the triplet were the patients with performance status of 1 and elevated LDH. For sure, this is an interesting combination with a toxicity that should be considered. Is manageable, but still is high with a high percentage of discontinuation. But I think that in the future, this may be something that we can propose for the so-called bad patients with brain met, elevated LDH, high tumor burden.